Good morning, everyone. We're starting this cornea ground rounds. I'm going to present a case, and the title of our topic, Corneal Pain Without Stain, Is It Real? And I'm going to present a case of a 60-year-old female with a medical history of fibromyalgia that comes referred to the cornea clinic due to both eyes chronic burning sensation, stabbing sensation, and photophobia. She denies any type of ocular history or surgery. She was treated previously with topical lubricants without a significant improvement in her symptoms, and she explains that the symptoms are extremely debilitating. She cannot work, she cannot breathe, she cannot even see the television. It's extremely affecting her quality of life. And when you have a patient like this, the first thing that you imagine is that you're going to find a case of severe dry eye disease with diffuse SPKs on corneal staining, but actually this was not the case. The visual acuity in both eyes was 0.6, improving to 0.7. She had both eyes normal eyelids without significant meibomian gland dysfunction or blepharitis. She had clear conjunctiva with normal vessels, clear cornea without staining. The tear breakup time and the Schirmer test were normal. The intraocular pressure was also normal, and the anterior-posterior segment, including gonioscopy, were without pathological findings. So how do you manage these patients that had no clear dry eye signs, but they have symptoms suggesting of chronic dry eye disease? How do you treat these patients, and how do you explain them that they have eyes that feel dry, but they're actually not dry? And this is how we manage our patient according to the Theophil Monocular Society for Dry Eye Workshop 2, the TIFOS DEUS 2. And these are the recommendations of the TIFOS. First of all, education regarding the condition of the patient, modification of local environment and diet, ocular lubricants, which our patient was already using, lid hygiene and wire compresses, and modification of offending systemic and topical medications, which the patient denied to be using them. Non-preserved ocular lubricants were used. Tea-tree-oil treatment for demodex was recommended, and she underwent puntal occlusion without significant improvement. Also, she was using overnight treatment with lubricant ointments. She also underwent physical expression of meibomian glands, which was very painful, extremely. It lasted for at least 2 to 3 weeks. The TIFOS also recommends IPL for therapy for meibomian gland dysfunction. The patient tried topical corticosteroid without improvement, so we gave her cyclosporine and afterwards tacrolimus without significant improvement. She was using for several months oral macrolide or tetracycline antibiotics also without improvement. The TIFOS also recommends topical antibiotic in combination of steroids for anterior blepharitis, which our patient did not have. Also, topical secretagogues or other drugs such as liftigras are recommended by the TIFOS, as well as oral secretagogues and autologous serum eye drops in the step 3. What we do recommend our patient was to use rigid scleral contact lens, which improved her symptoms, not 100%, partially, but it really improved her symptoms. But she came a few days after to the emergency room because she developed a corneal erosion. So when she was educated again and taught to use the contact lens, and she returned to the use of the lenses. The symptoms improved, but not 100%, and she cannot use them the whole day. Therefore, at the end, we recommended the patient to visit the pain clinic for management of her pain. So how do you explain this eye that feel dry, but they are not dry? They have no clear dry eye signs, but they have symptoms. And most important of all, they're unresponsive to dry eye management. And this is our topic from today, neuropathic corneal pain, a complex and often misdiagnosed and difficult to manage clinical entity. It is also termed corneal neuralgia, keratoneuralgia, corneal allodynia, or corneal neuropathy. The base of this presentation is a paper published by Dickman et al. In 2017 for ophthalmology. Let's remember that the cornea is the most densely innervated tissue in the human body by the nasociliary branch of the ophthalmic branch of the trigeminal nerve and other autonomic nerves. Nerve fibers arrive from the periphery of the cornea, they penetrate the limbus, and they arrive to the center of the stroma. They penetrate the Bowman's layer, when they are called the subbasal nerve plexus, and then terminal branches arrive to the epithelial cell layers. The periphery of the cornea has nociceptors, which are peripheral sensory fibers acting as specific detectors for injurious stimulus. A small review about the ocular sensory pathway. So the nociceptors in the cornea are activated after noxious stimulus such as mechanical, temperature, inflammation, etc. These first order neurons project to the trigeminal ganglion nerve and synapse with second-order neurons in the trigeminal nucleus caudalis. They decussate and join the contralateral spinothalamic pathway and then synapse in the thalamus. Then information arrives to the somatosensory cortex and the paralimbic region when they are perceived as pain. Afterwards, the pain responds with tearing and blinking as a protective measure. Neuropathic pain is any pain that is initiated or caused by a primary lesion or dysfunction of the nervous system. We have to know that neuropathic pain requires the confirmation of injury of some somatosensory pathway or peripheral central nervous system nerve, so we can call it a neuropathic pain. Neuropathic corneal pain, it remains an ill-defined entity. The epidemiology is still to be elucidated. Females are thought to be more affected than men. There's an increasing in prevalence, and it is a disease that is challenged to diagnose and to treat. Recent articles have attempted to elucidate the pathophysiology of this disease, but very limited literature exists on the management of neuropathic corneal pain. What is the pathophysiology of this disease? First, there's damage of the corneal nerve axons that carry the nociceptors, and in absence of any stimulus, there's a spontaneous activity which is translated as pain sensation, and this is called peripheral axonal injury, peripheral sensitization. Over time, it also alters higher order neural pathway, central sensitization, when, in absence of any peripheral or central stimulus, the cell body of the second order neuron displays a spontaneous activity that is translated into pain sensation. And this is what explains the symptoms of allodynia, photollodynia, and hyperalgesia. Allodynia is increased perception of pain in response to a normal, unpainful stimulus. Photollodynia, response of pain from light, and hyperalgesia, which is an exaggerated response from a normally painful stimulus or when the sensation of pain lasts more time than it should last. And this is what gives us the discordance between the symptoms and the normal clinical examination of the patient. The hallmark of central sensitization is pain that is disconnected from peripheral signs. What are the symptoms of this disease? Pain, discomfort, and aching, photollodynia, burning, irritation, stinging, severe eye pain, dryness, and redness. We can see that these are symptoms that can overlap with those symptoms of dry eye disease. It can be associated with ocular diseases such as dry eye disease, infectious keratitis, corneal cornea erosion, radiation keratopathy, or trauma. It can also be caused after surgery, such as refractive or cataract surgery. It can be also associated with some systemic diseases such as fibromyalgia, like our patient had, or trigeminal neuralgia. Also, it can be associated with medication-induced neuropathy such as chemotherapy, autoimmune diseases such as lupus, sarcoid, inflammatory bowel disease, or celiac disease, and diabetes mellitus, and others. It can be related with other comorbidities such as anxiety, depression, or post-traumatic stress disorder. So how do we diagnose these cases of eyes that feel dry but they are not dry? The diagnosis of neuropathic corneal pain is very challenging due to the lack of understanding of this disease and due to the minimal or absent clinical signs, thus masking the underlying condition. This is a proposed diagram for assessment and diagnosis of neuropathic corneal pain recommended by Dickman et al. And first of all, we need to assess the ocular pain and discomfort of the patient. We already know the symptoms of these patients, but these are patients that usually complain of prolonged dry eye treatment with multiple treatment failures. Usually, as we said before, this patient has an inciting event such as infection or surgery, and it can be associated to other non-ocular pain, neurological or psychiatric condition. We have to assess the symptoms, and another objective way to evaluate the symptoms and its monitoring its response to treatment is the recent validated ocular pain assessment survey. It helps us to assess pain intensity, frequency of eye and non-eye pain, quality of life changes, aggravated and associated factors, and symptomatic relief quantity. It also allows monitoring of treatment responses. We also have to check the functional somatosensory testing. First of all, we do it with the proparacaine challenge test. This can be a drop of proparacaine, lidocaine, ametocaine, any topical anesthetic. We put it in the cornea of the patient, and if the symptoms, as we see in this diagram, completely relieve, then we are speaking of a pure peripheral pain. If the symptoms partially relieve, then we're speaking about mixed combined pain. And if the symptoms doesn't relieve at all, or even there's worsening in symptoms, then we're speaking about centralized pain. And this is important because this is going to help us to guide on which treatment the patient specifically needs. It's important to mention that proper Rankine tests cannot distinguish between dry eye disease and neuropathic corneal pain. Another way to evaluate the functional somatosensory testing is the corneal stethiometry. It evaluates the tactile sensation, the function of the ophthalmic branch of the trigeminal nerve, and it can provide the first evidence of somatosensory abnormalities. The stethiometer is a device used to measure sensation, and we have a qualitative one, an easy cotton type applicator, which we have to use it before topical anesthetics are used, or a quantitative type such as the Cochet-Bonnet contact stethiometer or the non-contact stethiometer, the Belmonte. Afterwards, we have to assess the clinical examination and the signs of ocular surface disease, as well as the assessment of ocular comorbidities such as meibomian gland dysfunction, ocular allergy, conjunctival chalasis, recurrent erosion syndrome. We have to remember that patients with neuropathic corneal pain often present with symptoms out of the proportion to signs and may demonstrate minimal signs on slit lamp examination, even after using vital dyes such as fluorescein. And a very important step of the clinical assessment and diagnosis is the assessment of nerve density and morphology with in vivo confocal microscopy. Let's remember that to diagnose of neuropathic pain, we have to confirm that there's actually an injury of a nerve. Therefore, laser in vivo confocal microscopy is a non-invasive, high-resolution device that allows real-time visualization of corneal structures at cellular levels. We can see corneal nerves, we can see corneal cells, immune cells, even pathogens. Why is this important? Because in absence of clinical signs, it's critical to demonstrate that there's damage in the corneal nerves. Let's remember that the corneal nerves cannot be quantitatively assessed in slit lamp examination and that corneal biopsies cannot be readily performed. It also helps us in the diagnosis and monitoring of treatment efficacy. We can see here in vivo confocal microscopy examples in the single picture from the left from a healthy cornea and in the pictures from the right side of a patient with neuropathic corneal pain. We can see in the left normal branches and dendritic cells without nerve loss, with normal distribution. And we can see in the right that there's a different findings very suggestive of neuropathic corneal pain, especially the microneuromas or the neuromas, which are sudden swelling of injured nerves at their terminal endings, which are known to be specific of neuropathic corneal pain. Also, we can see tortuosity of the nerve, nerve loss, beating and reflectivity, but these last two are going to be dependent of the projection of the cornea. If there's some haziness, if there's some edema, it will decrease the reflectivity of the picture. And also, it helps us to see the response to the topical or any type of treatment such as nerve regeneration. And this is an example of treatment response. In the left side, the pre-treatment, and in the right, the post-treatment. We can see in the pre-treatment, in the black arrows, the microneuromas that improved after 4 and 6 months of treatment. What we know about in vivo confocal microscopy in fibromyalgia, the literature have shown that there is an increased complaint of ocular pain and corneal sensitivity in those patients with fibromyalgia, which they have any absence of organic pathology in the cornea, which is very suggestive of neuropathic corneal pain. Now, in vivo confocal microscopy have shown decrease in corneal nerve fiber density and length in up to 44 of patients with fibromyalgia. So we can suggest that these patients, many of these patients, are actually suffering from neuropathic corneal pain. And we can have some examples published by Odejans et al. In the left eye, a healthy cornea of a 19-year-old patient, and in the right, a 21-year-old patient with fibromyalgia. Also in the lower side, 57-year-old patient with normal cornea, and in the right side, 58-year-old patient with fibromyalgia. We can see that in patients with fibromyalgia, there was a decrease in density of the corneal nerve in comparison with the same age control patient. Now that we have diagnosed a patient with neuropathic corneal pain, then how do we treat them? How do we manage these patients? It will depend on the type of neuropathic corneal pain that we spoke before. And if we're speaking about a pure peripheral pain, then we have to offer neuroregenerative therapy or topical anti-inflammatory therapy. The first neuroregenerative therapy proposed is autologous serum tears, which is known to contain neurotrophic and epithelial growth factors and have been shown to improve the regeneration of corneal nerves, especially for dry eye disease. In this study published by Agarwal et al., it's a retrospective case control study of 16 patients with severe neuropathic corneal pain compared with 12 controlled, and they analyzed the pain severity from a scale of 0 to 10 and the in vivo confocal microscopy findings before and after treatment with autologous serum tears. There was no significant difference between both groups, the control and the patient with neuropathic corneal pain. And what I found interesting of this study is that more than half of the patients were after refractive surgery. Only 3 patients had dry eye disease. The duration of pain was a mean of 2 years, and more than 75% of the patients had pain more than 9 in scale, which is a very intense pain. Also, none of the patients had active ocular surface disease at the time of the study, but they still have very intense level of pain. Most of them were using other type of treatments such as lubricant and anti-inflammatory therapy such as letoprotenol. Almost half of the patients had other psychiatric conditions such as depression, fibromyalgia, and others. So what they found statistically significant in this study was that after a mean of 3.8 months of autologous serum tear treatment, the pain severity decreased to a scale of 3 plus less 0.3. Also, they showed that before treatment, subbasal nerve density was decreased in patients with neuropathic corneal pain, and there was an increase in reflectivity and tortuosity in cases of neuropathic corneal pain in comparison with the control group, and this was statistically significant. They also showed that after the treatment, there was an improvement in total nerve length and number, as well as significant decrease in the reflectivity and tortuosity. And even though this is a small study and it's retrospective, we have to remember that there's not enough proposed literature for the treatment of neuropathic corneal pain. Therefore, this is an outbreaking study which gives us a clue of a treatment that we can use effectively in the treatment of neuropathic corneal pain. Anti-inflammatory therapy, since there's injury to peripheral nerves, there's release of pro-inflammatory neuropeptides and cytokines from injuring and healthy nerves. Therefore, there's peripheral sensitization. For neuropathic corneal pain, it's recommended loteprednol 4 times a day with a slow taper depending on the patient's response. If we want to give another inflammatory therapy but a steroid-sparing treatment, therefore we can recommend cyclosporine A or tacrolimus or antibiotics such as topical or oral tetracycline and azithromycin. There are other types of treatments such as liftigras, interleukin-1 receptor antagonists, topical testers, and others that have been used in dry eye disease, which can also be beneficial. Another type of treatment for peripheral pain is going to be ocular surface treatment. We start with artificial tears, which actually it's a palliative treatment and they have short-term relief of symptoms. It can help the patients that have concurrent dry eye disease. Pontal plugs, the use is controversial because it can result in an increased tear lake, which can also increase the contact with allergen and pro-inflammatory mediators, therefore increasing the symptoms of the patient. So if we're going to recommend pontal plugs, it is recommended to be after we have initiated an inflammatory therapy. The treatment of meibomian gland dysfunction is important because by improving tear film stability and reducing inflammation, it can act as an adjuvant therapy for neuropathic corneal pain. It's recommended emulsion-based lubricants, hot compressed and lead massage, moisture chamber goggles, medical therapy with topical or oral antibiotics such as doxycycline and azithromycin, IPL, and others. The treatment of blepharitis and other ocular comorbidities may remove the inciting stimulus and mitigate the symptoms. Self-retained cryopreserved amniotic membrane is known to have anti-inflammatory, antifibrotic, and neurotrophic effects on the ocular surface. It is well tolerated in resulting in symptomatic relief and improving surface stainings in patients with dry eye disease. This smallest study published by Morkin et al. In 2018 in Ocular Surface, it was a retrospective case series of 9 patients who received Proquera, which is a self-retained cryopreserved amniotic membrane, for acute treatment of neuropathic corneal pain. What calls our attention from this study is that most of the patients were female, most of them had dry eye disease, and all of them had multiple prior treatment with lubricants, with warm compressed and lead massage, with lotoprednol, without significant improvement in symptoms. The fellow eye was treated with autologous serum tears for 6 months. So they collected 10 eyes of 9 patients, and they showed that after the use of a amniotic membrane, the pains significantly improved in 72.5% in the scale. Even those patients that had the amniotic membrane less than the planned time, the symptoms improved up to 63%. Another significant finding that they have is the total nerve density improved after the treatment and the dendritic nerve density decreased after the treatment. Once again, it's a small study, but this is outbreaking because there's not enough published literature that can help us in the treatment of neuropathic corneal cells itself. What about soft bandage contact lenses or scleral lenses? It is useful for the peripheral sources of pain, refractory to topical therapies. It can give immediate symptom relief. The mechanism is actually unclear, maybe due to shielding of corneal nociceptors from environmental stimulus, but the potential risk of infections with prolonged wear make it less attractive from the physicians. Scleral lenses have been shown to decrease light sensitivity and discomfort in 92% of the patients with other ocular surface diseases, such as dry eye. It has not been studied in neuropathic corneal pain. Patients with neuropathic corneal pain may experience immediate pain relief, but it may be very challenging in cases of severe hyperalgesia, in whom contact lens can provide a strong noxious stimulus just by putting the contact lens itself. What about mixed combined pain or centralized pain? First, we have to offer systemic pharmacotherapy. There's not enough data in the literature, it's scarce, and there's no randomized controlled trials that have been performed specifically of systemic treatment in neuropathic corneal pain. All the data can be extrapolated from treatment of postherpetic neuralgia or neuropathic pain elsewhere. As ophthalmologists, if we are not familiar with prescribing these drugs, then we need to work in conjunction with neuropathic pain specialists. Please refer these patients to pain clinic. We have first-line agents such as tricycle antidepressant and anticonvulsants such as carbamazepine, but we have other second-line and third-line agents that we can offer the patient, especially the pain specialist that knows how to really manage these drugs. Another complementary therapy, we can offer the patient cardiovascular exercise because it has shown to have act as an inhibition of pain pathways and in anti-inflammatory. Also, we recommend natural sources of omega-3 because it can improve the T-BOT and the Schirmer test results and may decrease symptoms of hyperalgesia. Also, meditation, mindfulness, acupuncture, yoga, whatever it makes the patient to improve their symptoms and whatever helps the patient in pain management, we can recommend. It has a positive impact in managing depression and anxiety. What about those cases that are refractory to all the proposed therapies above? In extreme refractory cases, there are experimental procedures, cases reports that have been reported in the literature, especially neuromodulation with deep brain stimulation or intrathecal drug delivery system with an implantable spinal cord stimulator. And I'm going to finish with this small case report, which I bring it up because I think it's important for us, for ophthalmologists, to understand how intense it can be, the corneal pain, for a patient to undergo a neurosurgery treatment. This is a 30-year-old female with history of anorexia nervosa, which had an uneventful LASIK surgery, and she had refractory both eyes intense ocular pain for 7 years. The examination was normal, so she was diagnosed with neuropathic corneal pain after in vivo confocal microscopy. She was using the previously proposed treatments such as eye monsters, scleral lenses, membrane stabilizers, other systemic treatments such as antidepressant, NSAIDs, tramadol, and this didn't improve her symptoms. The only thing that partially and transient improved her symptoms were autologous serum tear drops. But since the symptoms, the ocular pain was significant, constant, debilitating, she was referred to the pain specialist, already with autologous serum tears, bupropion, and clonazepam. She was recommended to have a ketamine infusion that gave her a 1 day pain relief, but it was associated with adverse events, so alternative treatment was considered. She underwent a trigeminal nerve stimulator, which afterward was explanted due to migration of the lead 6 months after and other small complications. So at the end, she was recommended to undergo intrathecal pump in the posterior intrathecal space to the C1 level. We can see it in the picture. She can have a self-administered bolus dose that are set previously by the clinician, such as fentanyl and bupivacaine. And this was the only treatment that improved her pain up to 50%, and she was satisfied at least for the year after the case was published. So please refer these patients to the pain clinic. In a conclusion, despite the significant impact on quality of life, neuropathic corneal pain remains an unrecognized and undertreated by ophthalmologists. Due to the limited understanding of the pathophysiology, the absence of clinical signs on slit lamp examination, the overlap of symptoms with dry eye disease, the lack of standardized therapy. What are the take-home messages of this presentation? Remember that these patients suffer from eyes that feel dry, but they're actually not dry. In vivo confocal microscopy aids in the diagnosis and monitoring of treatment. The management of these patients is extremely challenging, and there's an urgent need for long-term studies and randomized controlled trials. There's no single therapy that will likely be successful, and combination and interdisciplinary therapy is the mainstay of the treatment. So please refer this patient to the pain clinic. Thanks for your attention, and please increase the awareness.